Well, hello and welcome again to the Medical Mastery Podcast, the podcast of the Emerald Coast Medical Association. I am your amaranthine host, Don Davis, MD, and I am more than happy to be here today with Dr. Christopher Haberman. Dr. Haberman is a hematologist-oncologist, as I read here in my notes. Is that true?
Yes, that's true.
Oh, wow. This is going to be fantastic. So for all of you out there that are joining us here today, we're really excited about this conversation because we get to find out about a local physician here who is in our community and helping patients day to day. But also, I'm a bit of a cancer nerd. And I really love this subject in a lot of different ways because, I think it's been something that's really, in many ways, been the bane of existence. It's weird coming from a cardiologist that really worries a lot about cancer, but in many ways, cardiovascular disease is something that's pretty treatable. Cancer's ebbs and flows depending on the disease state of it. So we're going to hopefully get into all of that with you. So welcome.
Thank you. Glad to be here.
Yeah, well, let's start off, before we get into some of the interesting stuff, let's start off by, tell us where you're from.
So grew up in Savannah. That's where I was in practice before I moved here. So I was in practice about 15 years before I moved here. Medical family, my dad is a retired trauma surgeon. His dad was a doc, so one of the kids, I guess, felt obligated to go into medicine. I guess it was me.
And everybody else had stepped back, so you were left for...
One's a mechanic, the other one's a computer nerd.
Well, there's something about the logic that comes with this. I mean, I often say that biology is extraordinarily complex, but it is a machine in some sense. So there is that mechanistic thinking that I think probably, that can contribute to our understanding, but also how we try and make people better. So your dad's a trauma surgeon, all right? We've had a trauma surgeon here. Shout out Jamie O'Neill for being on there. Trauma surgery is, it's a very interesting life. How did he bring that home? How did you guys witness the trauma surgeon in your lives?
So it was unusual because my dad is 90, so he finished med school like in the late 50s, early 60s, went off and did residency in Maryland. He was military. Okay. So he ended up in Savannah as part of his military obligation and did a lot of surgery there. He was chief of surgery at the public health hospital in Savannah in the 60s. And all of a sudden, somebody got a brilliant idea to open an emergency room in a old hospital that had been there since the late 1700s. And they never had an ER like that. And they hired him and two other docs to come start an ER program. So 3 docs ran a 24/7 ER program for decades. And in the mid-'80s, he decided it wasn't for him anymore, and then he went out in private practice and just kind of did no more surgery, did occupational medicine. That was a very different lifestyle for him.
Yeah, trauma surgeons typically have shift work, or maybe it's a week on and then 2 weeks off, something along those lines. But it can be incredibly intense. I mean, you're obviously dealing with traumas, and you never know what's going to come in through the door. So I don't know if you ever talked to you about that kind of life or what that was like.
We heard all the stories, all the interesting things in body parts and all that stuff. Of course, we've heard all that, and you hear all the stories because in the 60s and 70s, medicine was so different. I mean, you could say anything to anybody. I mean, it just kind of slipped out. You observe something and say, wow, I didn't expect to see that, or you'd hear this story. So you'd come home with stories. I was the youngest of the 3, so I was still pretty little when he was doing all that. I just remember his hours were, he wasn't around a whole lot. Yeah. But he did get extended vacation in the summer. They'd work it out with the three docs. They'd figure something out. So we had a break during the summer, but it was difficult. I will say that. A lot of night work and a lot of shift work. Yeah,
and also heavy lifting. We're all going to lose patients in this game, and particularly trauma surgeons can see some brutal losses of patients, and so that can weigh on you. So to be able to kind of recollect yourself and move on to the next patient, that shows a lot of fortitude. So sounds like there was at least some good role modeling there for how to handle these situations. Also, old school there, which I love. I mean, they didn't have work hours back in. That was not a thing that he didn't get a chance to say, no, it's past my call time. I need to go home.
That's right.
He was not afforded that luxury.
No, call for them they called it heel to toe. It was every other.
Oof.
They just basically lived in the hospital, and they didn't go. They went home, but it was every other night. When they were on service, like the surgery service, trauma service, it was every other. So as
Q2
medicine
call
residents, we're used to Q4.
Oh yeah,
and they have.
And we
every
complained about that too. Don't get me wrong. No, the surgeons are a different breed, especially again the older school surgeons. So now, did he do military trauma surgery as well? I mean, was that where he got trained, is in the military? So
No,
battlefield.
he
or
went to
anything like
Hopkins, so he was trained there, and then
Hopkins, I've heard of it.
Yeah,
Okay.
yeah, one of those small hospitals.
Oh, I got you.
And then part of his military obligation when he was done, they gave him the choice of MASH unit or Savannah, Georgia, and obviously the rest is history.
Okay, I can see why he chose what he chose.
Yeah.
Well, look, that's really interesting. So you can start to see some sort of formative thought about medicine. Now, when were you in high school thinking, I'm going to go ahead and go into medicine, or did you have dreams of doing something else first?
As a little kid, you think, oh, it's interesting, the human body's interesting, all that stuff, and enjoyed it a ton. Always thought I was going to be a doc, but kind of lost my focus. I went to a private school, and college was really easy for me. I was well prepared. My prep school made it real easy.
Yes.
As a matter of fact, it was so easy that I kind of didn't do my job as I should have, and so I kind of lost focus, and medicine was not something I was probably going to get straight out of college. I had to have some detours in life.
Yeah.
Go to grad school, et cetera, and then got back into med school. Got back into that frame of mind and got into med school.
Well, those things are formative to us, and sometimes we take some extant kind of jobs or career choices and then come back to it. And I think it's, I've got several friends, colleagues here, former podcast guests that have taken a more peripatetic life choice in order to get to where they ended up. But it's nice to see how they ended up there. So let's hone in on that for a second. What'd you major in college?
Biology.
Biology, okay.
Yeah.
Was that kind of a means to an end, or were you fascinated by biology, or was that?
I think that was the most pre-med tracks went biology. Some went chemistry, some went biology, and few physics, but most of them weren't, philosophy or English. We had to do our basic sciences. So that was the route I chose that. And as I said, I really lost focus, whatever. Life happened, I don't know, whatever. And then I graduated, and a biology degree is not very marketable. It's not like you're going to find a job outside of a lab.
It's a stepping stone to something else,
I went
yes.
And, sold voicemail.
Oh.
Which was a really tough job because voicemail wasn't around. Everybody had answering machines.
Yes.
And they're like, why do I got to pay for voicemail? And then I came up with a little niche for realtors and kind of moved up that way and realized that wasn't for me, and then went to graduate school, and then that's what got me plugged back in.
Gotcha.
So started academics essentially all over by going to grad school, and then then I was a pharmaceutical rep, and then went to med school, or got into med school.
Yeah, this is sometimes great to go into something totally different like sales, where all of a sudden you realize, oh, I really don't like this. maybe really honing down on the books would probably help me get someplace where I can kind of use my brain in a different way. What'd you do in grad school?
Physiology.
Physiology. Excellent.
Yeah, so I was at a vet school. So all my colleagues were all veterinarians working on their PhDs. I was the only non-veterinarian working on my master's, and really was just to beef up my my application for med school.
Now, what were you studying more specifically in the labs that you were doing in
renal physiology?
Oh, very cool. Okay.
Yeah, so the guy I worked with and got my assistantship from, that's all he did. When you get in a big university setting like that, they carve out this one little thing.
You get more and more precise and specific, and may have been the upper pole of the kidneys. You can get pretty precise there.
It was fascinating because the stuff y'all use today, it was all the baseline lab work on omega-3 fatty acids and all its effects for antihypertensive properties and cholesterol and all that stuff. These were all FDA trials and things that we did. So it was pretty fascinating stuff. And this is the mid to late 90s, mostly mid 90s. So omega-3s, we didn't know anything about them, and then all of a sudden now it's a pretty hot topic for you guys the last 20 years.
Indeed it is, and it's also, it kind of harkens to how we learn things in on a meta scale. You have to start off with the physiology. It always starts with that. You have to understand how this process works, what the cells in the kidney are actually doing, how they're filtering. I mean, this is a tremendously evolved mechanism here in order to maintain the things that you want and get rid of the things that you don't want. And that homeostatic mechanism, because it can flex quite a bit depending on how much water and salt you've had. I mean, kidney is absolutely fascinating to do that. But you have to understand all that, and then we say, how can we take care of perturbations of this system in order to affect necessary changes that we want. So that must have been a great mechanistic way of thinking in order to kind of get your brain right about how to think about the body.
It's helpful in med school, I'll tell you.
Yeah, it is. Physiology I found to be difficult, but also one of the most rewarding things, because I kind of constantly talk about cardiac physiology. And now, the kidney physiology doesn't necessarily lend itself to eventual oncology. So there had to have been some sort of transition point along the way where you said, I'm never dealing with kidneys ever again, or did you feel that after you had gotten your master's degree?
It's hard to when you go off to med school, you don't know. You sort of know what you want to do. Even coming from a family with physicians, you think you know what you're getting into, but you really don't. As you know, they pressure in a lot of times in med school to make decisions about, maybe go do primary care. We'll give you this loan repayment. They lure you in and say, hey, you're going to do this. You're vulnerable as a first year med student. And you just don't know what you want to do. So you try different things. You learn the first couple of years, you do your clinicals. And when I was done with med school, I was actually going to do cardiology. That's what I thought I was going to do.
But you wisened up. Good on you. That was a very smart decision on your part.
You said it, not me.
It's true. It's so true that we kind of have these preconceived. I was going into primary care. I knew that going into it, and then came out the other end thinking something differently. But you also, it's Dunning-Kruger effect. You have no idea how little you know until you get into that. And it must have been quite an accomplishment on your part, because you would there must have been some doubt coming out of this, because I had taken my time during undergrad and I'd gone through graduate school. There's a feeling of relief of just getting in, and then you realize the fun hasn't really even started. You're just now getting into this whole thing.
Yeah, I guess I was one of the weird guys. I enjoyed med school. I enjoyed residency. It was like one of the most fun times of my life. My wife and I talk about it regularly. It was different. We didn't have much of anything, as you know this as well as I do. And
Indeed.
We enjoyed everything we did. The work hours were brutal because, like you said, we didn't have work hours. It was a different time in my life, but I enjoyed it. I enjoyed training. I had fun with it.
I really enjoyed working at high levels and really kind of, steel sharpening steel, and you really being pushed a little bit more to your limits of how much can you learn about a subject in 2 months, because you had 2 semesters in undergrad and now you've got 6 weeks. Go. And then you simultaneously, while you're trying to learn this subject, you're also feeling like, if I want to be a professional at this, I need to know this. It's holding yourself to a kind of a different standard that maybe I hadn't done before. And, it was.
Yeah, I think you realize when you're an intern, you think, oh, I know so much from med school. You just don't know how to apply it that well, because you haven't really been. Interns weren't unsupervised, but they kind of let the reins off a bit. Mm-hmm. And I thought my internship, I said, there's no way I can learn more than I've already learned. Then you realize in internship, I was like, I learned more in internship than I've ever learned in my entire life. Absolutely. In 1 year.
In 1 year, yes.
And then you go on to your second year when you're now the supervising resident, and you're saying, I can't possibly learn more. And then you're the supervising, you're the decision maker. There's an attending around and always available, but then by third year, you're comfortable.
Yes.
Then, like you and I did, went off and did a fellowship, and you think, oh, wow. And then you get out in fellowship, and you're like, I didn't realize I could learn. And then the real test is when you're out there after you finish fellowship and you're truly on your own. That first year in practice was eye-opening in the sense, I never thought I could learn that much again. Yes. And then it's exponential. And it sort of does plateau out with experience like everything, but I'm still surprised even here. I see pathology that I never thought I'd see.
You can
see
still
some
be
of
humbled.
The rarest stuff.
You can still be humbled all the time.
Oh, yeah.
Yeah, and, extremely rare cases stick in your mind. And that's something that I never got, as opposed to our dermatologic colleagues that can read a book and memorize everything. That was never my talent set. And so I had to match it with a story. And the story was typically a patient that presented with, all of a sudden I see this obscure thing and I'm like, oh, that's Henoch-Schönlein purpura. Or, that was when I can do, oh, that was Mr. Wilson. I know exactly what locked-in syndrome is now because I remember this patient that had this kind of thing. So now, so you're going through medical school. Now, we typically have to choose we're going to choose eventual paths, but you kind of have to think between medicine and surgery. Now, you would think you had some surgery kind of built into your lineage there. Did you consider doing surgery at all?
Not once. It's not that I didn't like it. I mean, we can talk about residency later, but it's not that I didn't like it. It just wasn't for me. It wasn't my calling. I was fascinated by it. I loved doing the cases. I had fun with it, but it just wasn't for me. I didn't want to do surgery. I just knew from the start. And the other choices, you're right. It's either you go the medical route or the surgical route. In gynecology, that goes more the surgical route as well. That just wasn't for me. Single gender medicine wasn't something I really wanted to do.
Yes.
And then pediatrics, I didn't really want to treat children and their parents. So
true.
So I went medicine, so I went adult medicine. And then that opens up all the opportunities, all the different fellowships and different subspecialties you can go into.
Now, so where did you do medical school?
Mercer.
Okay. And so then you move on from there after you finish the kind of one of the best years, which is fourth year of medical school.
I spent it all away. I didn't live in Savannah at all.
So you're doing various different places,
Yeah, so the first 2 years I was in Macon was where all the didactics were. And then the last 2 years we had the option to go to Savannah or stay in Macon. Well, I was from Savannah, so it was an easy decision. And then third year's standard for everybody. Yeah, fourth year I spent Vermont. I went all over the place.
What a great way to experience medicine in a lot of different places. And you start to see the similarities and differences between, you're comparing and contrasting different academic programs in various different places and kind of seeing rural, big hospital and those kind of things.
They're interviewing you as much as you're interviewing them for residency.
Indeed. And you're also, what you find out kind of in hindsight is you were almost interviewing for life. You're testing the waters in various different places to see like, could I see myself doing this? Could I see myself living here? And so that was kind of formative for me too. Now, so where'd you do your residency?
I did it in Birmingham. I did it at Baptist Health Systems there.
Okay, great. And so your work hours jump up a lot from medical school. The amount of knowledge that you have to learn while also working jumps up significantly at that point. You're really working for a living. But, you know, as you said, I loved my intern year. Like that was really a great time, and it was extraordinarily hard work. So sometimes you kind of forget about the work hours a little bit because you just again you learn so much and so many formative things. I can still have my attendings over my shoulders and hear them saying things about just general patient care that I think was great. So, and then how did you decide from there on fellowship?
It was fun. I was being groomed for cardiology. I was getting the guys at UAB. I was rotating with them. A couple of the big names there. I was doing rotations with them my second year. And then I was on call, I was on service, I was on wards, and took care of an oncology patient that wasn't having the greatest time at things. A lot of our oncology patients in the hospital, unfortunately, many of them, it may be the end of life. That's why they're in the hospital. They may have exhausted all the standard care therapies and not doing so well. And their doc really hadn't addressed kind of, code status and, hospice or what are the treatment options. I mean, this is in the early 2000s, so there wasn't, once you kind of exhausted treatments, there wasn't a whole lot left beyond kind of routine chemotherapies. And I took care of him. The husband or the patient wasn't doing well and clearly looked like he was imminently going to code that night. And I had this lengthy discussion with a family member. And after tears with them, certainly with me, it was very emotional. Unfortunately, the patient ultimately passed, was a DNR, so he didn't have to go through being CPR, et cetera. And kind of went on and did my job. And about 3 or 4 months later, I got a letter in the mail from the spouse's wife. And it was this long, drawn-out letter that said, I appreciate you spending the time with me. Ultimately made the right decision. I'm glad we met with you and not somebody else. I'm glad we didn't pursue CPR, et cetera. And it hit pretty hard. And then I realized that the oncology patients, much like you guys, I mean, they're very thankful. When you're doing something for them, they're extremely thankful, and it was very gratifying, and it was entirely different than some of the other subspecialties I've been exposed to. As a resident, you get exposed to the worst in oncology patients because they're the sickest. You don't always see what's going on in the clinic. And then I realized I better get in the clinic and see what outpatient oncology is like, and that's what flipped the switch.
That is awesome.
Yeah.
And it highlights a discussion that we as physicians should have with patients, which is meaningful thoughts on outcomes, of changing goals of care, of palliative care, of DNR. Patients, in my experience, they understand typically what's going on. They at least have some sort of visceral feel for if they're dying. And so to have that direct talk with them and talk about the things that you can and won't be possible, I think that is just, it's so formative, and it is an incredibly emotional experience and is one that is absolutely formative. So I've had a couple of those experiences, same thing in residency, that certainly moved me. It didn't move me towards oncology, though, I can tell you that. As opposed to, so good on you for feeling that out.
Well, oncologists all are a little different, as you know.
It's true. Cardiology is pretty different too. So now, one thing that's a little inside baseball from the internal medicine perspective, because we know this, but for the lay audience out there, you have to do 3 years of internal medicine residency, and then you can choose fellowship if you so choose to after that. And there's several different subspecialty fellowships, whether it be nephrology or cardiology or infectious disease or hematology oncology, and you would think that. One of the things that kind of surprised me is that internal medicine doctors, the hospitalist team, they don't write chemotherapies. That is basically all to the oncologist. So once you hit that standpoint, once we went to this patient has some sort of aggressive cancer, we're going to start them on chemotherapy, that went over to the oncologic world and didn't really come back this way. So there is some sense of you almost not knowing about that until you really get into it with fellowship. Was that your experience?
Absolutely. In the first few months of fellowship, I'm sure it was the same for you. They're all focusing on, they put the big guilt on you. Oh, no one in this program has ever failed the internal medicine boards,
Yes,
and you're not going to be the first.
That's
and then
right.
you've got to learn all these new drugs that most of them we've never even heard of, because all the stuff we're tested on is on the ancient chemotherapies that are still around and effective. But a lot of the modern therapies, they come and go because a new one replaces them within a year. So there's just this tremendous pharmacologic turnover. So you're trying to learn all the new pharmacology, the dosing. These drugs have narrow therapeutic windows with dosing. You don't want to give too much, too little, whatever. And then you're studying for your medicine boards, which is your biggest test to date.
Yes,
clearly,
indeed.
because if you don't pass your boards in fellowship, that is not well received.
Does not look good.
No,
Yes.
Many times you don't have a job.
That's right. That's right. And
So you have all this pressure. And medicine boards were, I want to say they were in August, and you start fellowship around, I started the week before the 4th of July, but usually late June, early July. So, you're thrown into the brand new system. Most of us go to a new hospital because we don't stay at the same one we're at. And then you're having to do your medicine review and maybe go off and do a board review class. There wasn't a ton of online options just because it wasn't around.
Yes. Well, and the other thing about this that I found is that it was, as a cardiology fellow, I'm expected to know cardiology, and
Yes.
I didn't. Now, I certainly knew the basics from internal medicine side, but in terms of real bread and butter cardiology, you have to learn that. Now, you're expected to know it because you're a cardiology fellow at that point. The patients expect you to know that, and so you feel almost out of suit because I've got to look up a lot of these things. Like, what on earth does this medication do? I don't know what this kind of thing is. And, it's something that you're going to be expected. You didn't really know how to treat cancer at that point when you're being thrown into it.
No, not in the first number of months. It's just this, again, that's that learning curve. You think you can't possibly learn at the rate that you're going to, and it's exponential.
Yes.
And then it kind of all seals in all the primary care and everything else. Because a lot of times when you're in fellowship, we're able to moonlight as internal medicine attendings on round services and things like that. Or one of our attendings, a lot of the oncology attendings did medicine teaching as well. They'd go on vacation and say, hey, can you fill in for me and do rounds this week? And, we'd always oblige because if an attending asks you to do something, yes, sir, it's what do you want me to do?
Yes.
But so you learn all that. You're applying it now back to all the stuff and it's just, again, the learning curve's tremendous. It is truly exponential.
Did you find at some point, because we're going to talk about some specifics about chemotherapeutics, radiation, and kind of our bread and butter oncologic therapeutics that we have, but did you find yourself that as you matriculated through first, second, third year of oncology fellowship, that things started to come a little easier to you? There was a little bit more intuition that could guide you. You were making the right answers on things?
Absolutely. You start picking, it starts getting easier. You see, it's just a lot of it's pattern recognition. Once you've seen the 8th colon cancer, and the treatment really isn't a whole lot different for the other 7, you see the patterns. It's like, DKA, it's like all that stuff. You learn the pattern recognition, you get familiar with it, and then it's autopilot.
Yeah, part of the training, I think, especially in oncology, had to have been, yes, you have to learn all the pharmacologic standpoint, and certainly all of the physiology and cancer biology, but you're also learning a lot of emotional connection with patients. I mean, there's very few things I could think of that probably cause more fear than a cancer diagnosis in patients. And so they're going to come to you in an incredibly vulnerable state. Part of that is empowering, and it's helpful to us because we get to see people, and really come to them altruistically to help. But that has to be an emotional burden to carry home and into other relationships.
It's like all forms of medicine. There is no doubt. There's an emotional component. Patients will either open up to you or they're not. They're not going to open up to you. So if they want to open up, you try and get involved as best you can. But you also have to have a little bit of a barrier for yourself. So when you go home, you're not an emotional train wreck either. But we all have good days and bad days. There's no doubt.
That's true.
It is tough. There is an emotional component that you don't always see that in fellowship as much, because you're just learning. You're in that book, and your attendings are all over you and pushing you around and just getting the job done. And you just have massive amounts of work, because you're at these massive medical centers that we're nowhere near that anymore once we get out of fellowship, unless we stay in a big city.
That's right. And
it's a different animal.
The number of patients are the number of patients.
True.
Sorry, we've got 40 on the service today. Get to work.
That's right.
And that's what you have to do. Everybody deserves treatment. So let's talk about something that many patients, fortunately, don't know a lot about, and that is probably one of the, I don't know if scary is the right way to say it, but one place that I don't enjoy going at all, which is the bone marrow transplant unit. That is a place where you've had to spend a fair amount of time just in your training alone. Why don't you talk to our lay audience perhaps about what the bone marrow transplant unit is and how that kind of comes into play, and why that is it's a really tough place to be, but good God, do you guys do excellent work in those places?
Yes, so I'm not a transplant doc, but as you said, we all do, just like the
bone marrow
EP
units,
for you guys. I mean, you spend time there as far as training. We have a lot of patients here that we send for transplant. So there's no transplant centers here locally, but as far as spending time in a transplant unit, these patients can be the sickest of the sick. They're always teetering on a balance beam, and we're sitting there nudging them to push them off with all these different perturbations that are out there, infectious causes, and they're just the sickest of the sick as they're trying to recover. It's basically an ICU ward that's all isolation, because everybody's got a mask up and gown up, because none of them have immune systems. The transplant units, transplants today, they're the same as they were when I was in fellowship. You have auto transplants, which is where I donate my own cells for my own transplant. And then you have the allos, which can be related donors. So it's another person donating to the patient, whether it's a related donor or an unrelated donor. And each one has its own set of mortalities and risks and et cetera. Then that just will bridge on for the rest of the talk, I know, but there's stuff called CAR T, and then this bispecific antibodies. I mean, there's all this stuff that's coming that I think eventually will land back into the community and the smaller programs. But right now, transplant really is in the bigger academic centers for the most part.
Yeah.
But they are potentially the sickest patients, because they have no immune system. They just can't fight anything. Any infection is potential life-threatening.
Yeah, and this may be a good segue transition point to talk about some of the treatments that we use for cancer. And we'll kind of cover what cancer is and some of those issues too. But for many cancers that we have, including a lot of the hematologic malignancies, that's blood-based cancers, if it is such an aggressive cancer, or if it is growing so much, or if your bone marrow is putting out so many of these cancerous cells, we come upon a treatment strategy where we try and obliterate the bone marrow. And we try and obliterate the bone marrow, typically using poisons. That's effectively what chemotherapeutics are. The hope is that we will kill enough of the cancerous cells, but still leaving you intact. And that's a very narrow balance sometimes. So for these patients that are in bone marrow transplant centers, you are obliterating their entire blood supply, their entire bone marrow supply, and therefore their entire immune system. So they have no ability to fight off any infection whatsoever. This is where you learn in training that one branch of the white blood cells are the neutrophils, some of the white blood cells, and there is no greater emergency than a neutropenic fever. That means somebody that's still able to mount a fever despite them not having very many white blood cells at all. That's a true emergency. They are incredibly sick because your white blood cells can kind of mediate a lot of your fever resistance and or your ability to create a fever. So these are extraordinarily sick patients who are really teetering. They can't eat anything. They don't look well. They don't feel well. Many of them can't even talk. And it was a very formative experience going to codes in bone marrow transplant centers. That will really land home on you. So that's, I don't know, that was a very formative experience to me, and going through training that I think really landed on me and made me say, I don't want to do this.
Yeah, transplant's tough. It is a tough subspecialty within HEMONC, I tell you.
Yeah.
And you're limited so much geographically too, because there's not transplant centers everywhere. So, but yes, they are the sickest of the sick, and you absolutely wipe out their bone marrow. They have no way to fight off anything. They're on multiple antibiotics, antifungals, all that stuff, and many times on medicine to maintain a blood pressure because they need pressors. Yes. They're getting gallons of fluid in them. They're not eating. Nutrition status is tenuous at best.
Yes.
They're getting nutrition through a central line. I mean, it is tough. They have mouth sores. It's a difficult time. Fortunately, the mortality rates and things are better. Supportive care is better. The treatment of this problem called graft versus host disease with allo transplants is better. I mean, there's definitely improvements, and supportive care is much better than it used to be. But it is an exciting time in medicine for everything. We always have up and coming things. We're trying to limit toxicity and trying to use less chemo, more targeted treatments and things like that.
Right. Getting more specific for the cancers that we are trying to treat there. Now, I'm going to transition back. So you finished fellowship, you come out to work in Savannah. Are you doing private practice at that point? Mm-hmm. Okay, so you went into private practice. There's always a pull generally towards academia. That's what your training programs are trying to get you into.
With the training programs, yes. With us, no.
Yes, exactly. No, so we're ready to get out there and start seeing people. How'd you find your first years of practice?
I enjoyed it. I really did. I enjoyed where I was. I had really supportive partners. It was a bigger group at that time. Counting me, there were 7. I was the newest guy, so the last new guy was hired about 5 years before me. I knew a lot of the docs because my dad was a doc in the community, so I knew a bunch of the senior partners. They're very supportive. They didn't kind of throw me to the wolves. I didn't experience that. Yes, call was difficult, but if I had a question about procedure things, because that's the issue when you're brand new in practice, is how does this hospital do it? Because I just came from one that did it entirely different.
That's right.
Procedurally, you got to learn that. And I had good mentorship from my senior partners if I needed it, but you also have that, you don't want to do that. You don't want to be the one that's calling your senior partners all the time either. But yeah, it was fun. We had a good time, learned a ton again, that exponential learning curve, met a lot of good people. But the thing that I think a lot of lay people don't understand is when you start a new job, especially in private practice, you have to build a practice. It doesn't show up on your doorstep. I mean, these busy docs of mine, yes, they needed to hire somebody because they had outgrown, being able to see all the patients efficiently. But it's not like you walk in day one and you have a busy practice. It takes years to build a practice. Indeed. And that's why physicians don't like to move. Mm-hmm. It's hard to start over. It's a challenge. It's, you got to get out there and be a politician, shake hands, smile,
meet
and
the primary cares, yes,
meet everybody.
Yes.
Because especially now with hospitalists, and you don't see a lot of primary care docs, but it's tricky. So it's scary all in one. But I mean, your senior partners hopefully look out for you. And my practice took great care of me. I cannot say enough good things about them. It's And we can get to why I left later, but yeah, they did. They took good care of me, and in turn, I mean, I was very successful and did a great job there and had fun.
Yeah, yeah. I mean, and so you say 15 years that you practice there, is
Yeah,
that right?
just shy of 15 years.
Well, let's get into that. How did that eventually take you to coming here to Panama City?
So my wife's from Southwest Georgia, and they used to vacation here. I mean, I grew up in Savannah. You know, the only beach I knew anything about was Tybee Island, and the water's brown. You take
Yes.
a cup of water from Tybee, you can't see the other side. The sand is brown and hot because it absorbs all the heat. We have a 7-foot tide on average, so all you're doing is moving chairs all day long. You know, none of this stuff. You come here, and it's like, this is Caribbean clear and
It
green
is,
and beautiful.
it is,
And
yeah.
so,
Silk sand, yeah.
so we'd go on vacation, or she used to vacation here, so she introduced me to it, and I said, wow, there's another beach out there besides going, you know, the Caribbean or whatnot, and then Savannah, and loved it here, and then opportunity came available, and it worked out well. My practice was going the wrong direction, in my opinion. They had formed an alliance with a hospital. We became less autonomous. And once that happened to me, it lost the spirit of medicine. I used to go to the satellite clinics because that was my thing, was to do rural medicine. I enjoy going to the small towns and go out there to the hospital and stuff like that. And it was always real busy. And then with the bigger hospitals, they kind of wanted to abandon that model to a certain degree, or they wanted to change it. And I was like, that's just not the spirit of the agreement. So I reached out over here. We'd had property over here for a number of years, so I realized that transition wouldn't be too hard. It's just timing-wise wasn't the greatest time to move here because of COVID, but
Sure.
you can't always pick what time. And decided to make the move in 2019, and I moved here right when COVID got started in March of 20.
Yeah, and you know, we were still recovering from Hurricane Michael, which was you know, that still has a long tail here, and so COVID was a very interesting time. And you know, it's a part of that. You look back in hindsight and we didn't really recognize it at the time of how formative it would be, but you know, we were still out there, frontline infantry, and seeing a lot of very sick patients coming in, and that it's really that was a difficult time. But you made the transition, and you have to know a little bit more about business at this point. I mean, it's not just the oncologic medicine or the physiology or anything like that. It's you've got to learn how profit and loss sheets and other things like that. So
True.
And so you came over here, you've been practicing, excuse me, ever since. How's it been going here?
It's great. I can't complain. I like the community. Patients are very grateful. I think you're starting to see the attitude change here locally. When I got here, it seemed like everybody wanted to go out of town to do all their medical needs, and then COVID hit, and it made it. I think it put up a lot more barriers. But then more docs started coming here.
Yes.
We started getting more and more docs and subspecialists, and hopefully that mentality is changing where I don't have to go out of town to do all my treatments.
That's exactly right.
That was the biggest hurdle day one. I was just so frustrated that every time I'd see a new cancer patient, like, oh, I'm going to MD Anderson, or I'm going to Mayo, or I'm going wherever. And I was like, you understand, we train at these programs. We didn't train in Panama City. You know, we bring that expertise with us. That's we live here because we want to live here.
That's right. And you are perfectly comfortable with saying, whoa, this is a very rare cancer. You would be served best by going to MD Anderson or Mayo or something along those lines. Or this is wheelhouse, and we can take care of this with you being at your home, which is much more favorable than going to get hotels and other things, and the travel of all that stuff. I mean, certainly, you know, the physicians that I found that are most confident in themselves would say, get a second, third, fifth opinion. I'm totally fine by that, but I will be honest with you about the things that I'm comfortable with, and I'm pretty comfortable with this, and we can take care of this here and at your own comfort.
Yeah, you hit the nail on the head. If you run into a doc that says don't get a second opinion, you need to run.
Run, yeah. Run, don't walk, yeah.
Yeah, because you're right. We're all comfortable with that because we're comfortable in our decisions. Somebody overlooks our shoulder at an academic center and says, yeah, I agree with exactly what you're doing at home. Stay at home.
Yeah.
It's reassuring to the patient, though.
Yeah, it's reassuring. I don't necessarily need there, but either way, the patient's getting that, you know, because they're having to suffer through this. So now, you know, you had talked about building up your practice and how difficult that is. I would bet it's a little bit more difficult to get into your office now. Is that fair to say?
Yeah, it is. I mean, it's definitely busy.
Yes.
Because, again, started all over March of 20, and then you can't go out to the community because it's shut down because of COVID. So you can't there's no way to introduce yourself. You have to do paper media, you have to do internet and social media, and that's really starting to explode in the early 20s. And
yes,
it was tough. It was tough to build a practice. Certainly there was already referrals that partners were kind of feeding my direction to get me started, but yeah, you got to start over again. But yeah, it's busy now. We're actively recruiting. It's no secret that we're actively recruiting. It's tough to recruit here. I'm not sure I understand why.
I don't fully understand it either. Beautiful beaches. Your money goes a long way in the state of Florida. There's no state income tax. Maybe we can get curiosity marketing on that. Chris, you gonna work on that for us? Okay, so
I would love it, because I mean we're using headhunters now.
Yeah.
We've had candidates come out, and that sometimes it's the spouses, whether it's male or female.
Yes.
They're used to the big city,
That's right.
The amenities that go with being in a big city. Then they talk about food. They talk about all the big city stuff. It's like, but you don't understand. The quality of life is so much better. You go to the big city, just like cardiology and every other subspecialty, primary care, I don't care. On the street corner, there might be 15 doctors right there.
15, that's right.
And the competition is different. You have these communities that are actively recruiting and certainly saying, hey, please come here. We'll make it work any way you want it to.
Well, and meanwhile, I can golf cart to my kids' school, which
Right.
is, I mean, this is, and you can get waterfront property here, and you can, I like to say I could go from my house to England, which is, not something you can say in a lot of places. So
you could.
It'd be a trip. So love this community, and really glad that you're here and have built such a busy practice here. Now, I want to transition to start talking about a hobby horse of mine, which is cancer in general, and that's something that we haven't really spoken about exactly. Why don't you tell our lay audience and our professionals, what exactly is cancer?
So I always use the example of a cancer cell as a cell that has an on switch and no off switch. So it ignores all the normal signals when it touches a neighboring cell just to shut down. So normally it's just like building a neighborhood. You don't build on top of your neighbors. You build up to your property line or whatever, and then you're done. Cancer cell ignores all boundaries. So once it gets that abnormal mechanism, DNA switch, whatever it may be, then it just grows and doesn't stop. Now, some cancers, as you mentioned, some can be aggressive, meaning it grows faster. Some grow slower. Some are observation alone. Some are you need to start treatment yesterday. I mean, there's all different types, obviously, treatment options, growth rates. And something that's an aggressive cancer doesn't necessarily mean it's a bad thing.
Yes.
I think that's a big misconception out in the community is, oh, it's aggressive. No, well, you just want to start treatment. Aggressive many times means it'll respond to therapy very quickly because those cells that are actively growing are more susceptible to the toxic effects of chemotherapy or the immune therapies or whatever. So, but yeah, it's on switch, no off switch. That's what I tell people.
Yeah, and so this really starts to get into a deeper level of the physiology of cancer here. So we're really running two different dichotomous ends with all of our cells in our body. There's something called the Hayflick limit, which is the number of times that your cells can double, grow, and there's a limit to that amount of time because at some point those cells are going to senesce, which is our doctor way of saying die. This is the reason that we age, is because our cells and our organs and our various different tissues are senescing over time. But if they don't senesce, that means they start to grow forever. And if they grow forever, that's all of a sudden cancer. So those are the two dichotomous ends that we have. Are we going to age? Are we going to grow forever and have cancer? And those are the different areas. Now, our bodies are forming cancers all the time. We are forming, there's different cells that all of a sudden break their slippery bounds and start to go out of control, but we have an immune system that tends to find those and kill those. Other cells say, hey, look, there's this guy over here that's building his house on my property. And so our immune system takes care of that. And that's happening all the time with this. But occasionally some slip by. And that's what starts the massive or the meta cancer issues that we end up dealing with. Now, when you think of cancer in your mind's eye, do you think of these as all separate types of illnesses or separate types of disease processes, or are they all kind of the same in your mind?
I look at them differently because all the treatments nowadays, everything's catered to the specific type of cancer. So it's very, very cancer specific, most treatments are. And a lot of it's down at the DNA level looking for mutations and things like that. So we're always trying to get away from the toxic effects of chemotherapy to find something more targeted, take advantage of a mutation a cancer cell may have, growth pattern, whatever. I mean, these scientists, that's what they're looking for. By honing in on a target to take advantage of, then you many times can overlook some of the common toxicities that you see with a generic, as you said, poison, kind of like weed killer, many times might kill our grass. And that's the effects on the bone marrow, whatever. Whereas a targeted therapy may be specific to one specific mutation that only this cell's going to have, or only a handful of normal healthy cells may have. So the toxicities many times can be limited.
Yeah, in other words, you're not going to feel that you're taking this medication. It's not going to hit your cells nearly as hard, cause the sickness and the nausea and all the other things that go along with it. It's really going to be focused on killing the cancer cells. Really a modern marvel in terms of our pharmacologic armory that we have. So yes, we want to get more bespoke. And I think you said something really sage about the aggressiveness of cancers, that super hyper aggressive cancers respond very well. I think, and you'll correct me here, things like Hodgkin's lymphoma, a specific type of your lymphomatous tissue grows excessively. It is a blood cancer is how it's considered, and it is hyperaggressive, which means you can give a certain set of well-tested chemotherapeutics that cause the tumors to melt away, I think is the verbiage that was used, at least in training.
That's exactly right. Yeah, unfortunately, sometimes these aggressive cancers, by treating them and they respond so quick, then they cause other problems downstream.
Yes.
So we're preventative. We try to be preventative of that and trying to explain that. But it's overwhelming to the lay public. I tell patients all the time, I say, I try and explain this to doctors and they don't understand.
Of course.
I said, you're getting a crash course and, you watch out what you read. And we mentioned briefly on AI and Google and all. You just got to watch what you read. And everybody wants to know everything instantaneously about whatever today. If your car has a squeak, you're going to get on Google and try and self-diagnose, and you're going to go to the mechanic and say, I think it's my fan belt, and it might be, Lord knows, whatever it might be. So it is, and we're the WebMDs and stuff of the world. They're helpful. But they can be a hindrance for sure.
I will say this to my patients oftentimes. You can look up any of the stuff that I just said. I wouldn't advise it, but you can go look all of this up, because again, you start to go down this pathway of seeing the worst. One of the things that we didn't even realize, honestly, we were getting trained in is the wisdom, is to kind of know the things of like, yes, this could be subacute sclerosing panencephalitis. It's not, but I understand where you could look at these symptoms disjointedly and the AI, the algorithm would spit out, oh, it's this thing over here, or you can have, there's ST segment elevations. Not all ST segment elevations are myocardial infarctions, okay? Not all of the dangerous EKG changes are indicative of you having a heart attack. But if you go look that up immediately, they're going to say, get to the hospital immediately whenever. So you kind of have to talk patients off the edge sometimes and say, like, look, again, yes, I'm saying.
It's not sometimes, it's a lot of times. Google with a ingrown toenail will have you an amputation tomorrow.
Indeed, a necessary amputation. Right. And it's part of kind of the interaction that I have with patients, and I say this oftentimes on here, which is that I know what I want to do typically within the first minute of seeing a patient. I've got an idea of exactly where we're going to do. The rest of the time, and I'll spend a fair amount of time with patients, is going to be getting you to buy in, for getting the patients to think, first of all, that I care, which I do. Secondly, that I understand what I'm talking about here, and I can explain it a little bit to you so you can kind of get on board a little bit with it as well. These are incredibly deep. I mean, for me to ask you, tell me about cancer. I mean, centuries of work have gone into this kind of thing, and so that's something we have to consider in our patient interactions.
Absolutely. Yeah, you're right. We know most of the time before we walk in, we know exactly what we're going to do, and it's the rapport, it's the compassion, et cetera.
Yeah. One of the things that I found that was interesting with my limited experience with oncologic training was that, sometimes on, for example, cardiology, we have some guideposts. We have a first-line therapy, a second-line therapy. We have some general, which statin do we want to use. We've got some idiosyncrasies that we would consider there. I was surprised at how once you grade and stage a cancer. So in other words, feel out how aggressive it is, if it's advanced, how far it's advanced. Once you do that, then it goes into an algorithm where it kicks out this is the chemotherapeutic regimen, this is the dosage that you should be giving to a patient. Most of the time, if not all the time, it's dosed based on your body surface area, so somewhat proportional to your size. And it's kind of, once you get all this information in, we've got just this hollowed, august body of knowledge from oncology studies that says, okay, this is the thing to do for this patient. So there's some art there, but there's still a lot more of it goes to the computer system, it spits out, this is the regimen you should be using.
It is algorithm based for sure. Mm-hmm. I mean, that's for consistency. 30 years ago, you had guys shooting from the hip. I mean, they just would say, I think this will work. It looks like it might. And they just kind of make up some own regimen. And, you didn't have a lot of choices 30 years ago. I mean, I can't imagine how many drugs there were in the mid-90s compared to where they are now. You talk to some of the older attendings in training, they're like, we had 5 drugs when I started in the 70s. I said, you don't understand, you have this many now. But you get these guys shooting from the hip, just kind of making up a regimen of sorts. I mean, they think it might work, and
it's like sorcery or alchemy or something.
The guidelines and algorithms are important. They're tried and true. They've kind of gone through all the big medical centers and kind of their approvals. We all have guidelines. I mean, American Society of Cardiology has guidelines. We have guidelines, and we try and stick to them as best we can. Unfortunately, there's not everybody fits in that box. And then it's, like you said, then it's wisdom, and then it's knowledge and it's experience. I used to hear from patients all the time, I don't know, 4 or 5 years into practice, I want to see the new doc. They got all the knowledge. It's like, no, I probably don't want to see the new guy.
Yeah, that's right.
The new guy's still got to learn how to apply all the knowledge. Yeah, they may be up to date on some of the studies, but we all keep up with that stuff. Patients don't quite understand that. They have the reverse idea of what's actually true.
Yeah, and when you look at chemotherapeutic trials, new drug trials, it's sometimes shocking to see results that are, say, taking a median survival, I'm going to make up something for pancreatic cancer, say, and takes a median survival from 7 months to 10 months. And that is a huge breakthrough. And it's hard for us to think about, because we think in our mind, well, that's just 3 months. And in reality, that is such a tremendous breakthrough. Also, you're taking into account statistically, this is average on patients. So clearly there's a signal here that whatever we are introducing is making some significant difference. But, our oncologic colleagues will say like, oh no, this was big, in order to get those kind of, it seems like medial improvements, but they're actually really huge things when you look at these trials. Now we're going to move on to, how is AI going to affect your world?
Well, that's an interesting one. We're in the infancy of AI, I like to think. And it's, AI to us 20 years ago was autonomy with computers. They're going to rule the world. They're going to do all the nukes and all that stuff. And it's just, it's good at pattern recognition. How much does it self-learn? I don't really know. I'm not a computer guru, but it's going to change. I mean, I have patients pull up a chat GPT or something, and they say, this is the stage colon cancer you said I had. This is what they're going to tell me. And they print out this 7-page report and hand it to me. And they're like, do you have time to read it? I was like, no. And I said, I'm sorry, I don't know what you're trying to tell me. But yeah, AI, I think it's going to change things a lot. I think it allows, the computers are able to search vast amounts of information instantaneously. Yes. The problem is the experience isn't there. I mean, it's you still got to have the human mind to kind of look at that and say that's ridiculous. So an AI bot couldn't tell, if I got a 95-year-old patient that's had a stroke and a heart attack and they're in a wheelchair, it'd still say treat them aggressively like a 40-year-old patient, because it's not looking at them and making a clinical decision about what we think is best, and then the family inputs things. The patient obviously has the ultimate decision. But yeah, AI is going to change medicine a ton. I think it's going to change what we all do. I don't know that it's going to put us out of business per se, but it's going to change things dramatically in the next 15 years, I'm sure, because we've seen the change just in a year.
Yes.
It grows fast.
Well, there's certainly the knowledge base that I think is going to help with. I'll come back to that in just a second. But I do like the idea of AI helping us with the more tedious parts of our lives, like documentation. If it could
Absolutely.
just be, if you could just say, we're going to do CHOP R on this patient. And,
Right.
it just sends that out to the pharmacy and that's taken care of. That would be a huge, because, that gets us to seeing more patients. That gets us home to our families a little bit more. That gets less of the tedium of doing these notations at the end of the day. Because, your thought process, your value is there, the interaction with the patient, making the medical decisions. It's not really the documentation. That's for billing purposes. And so I see that would be extraordinarily helpful, and we've already started to incorporate that a little bit into our practice. So.
Absolutely. I use an AI dictation system, but there's still a human there.
Yes.
There's a human that reviews it and makes sure, listens to the actual transcription and says, yeah, that's not quite what he meant.
Right.
But it's that AI transcription is pretty good.
It's getting good. Yes. It's being able to sift through the conversation and kind of pick out the germane parts, which I appreciate. I've given this example before. I'll often say to patients, I'm assuming you're not doing a whole lot of cocaine or methamphetamine. And they typically come back with, just a little bit on the weekends. And the note will say, patient admits to cocaine on the weekends. And so you have to kind of be able to catch a little bit of some of that tongue-in-cheek parts. But I think it is getting better. Now, in terms of the knowledge base that it's coming from, you're right that, it is physically impossible for you to read every single oncologic journal and every single trial that comes out. That is just not possible. So having this repertoire of information that it can sift through, that says, maybe if you bring it along with you on cases that says, hey, did you consider blank on this? And then you can kind of use your own wisdom and your own experience to say yay or nay. That might be helpful to us.
Yeah, I think so. I think it'd be helpful. I think it'd be interesting to see how it affects radiology too.
Oh yeah.
Because of the pattern recognition and stuff. I mean, it's good at picking up patterns. I'm not going to ignore that.
It absolutely can. And yeah, I think the really technophiles among us would say radiologists are cooked. So because the AI is going to get very good. Now that affects my family for sure, but maybe pathologists too. I don't know.
I don't know. I mean, I think they're still going to have gray-headed docs that are out there with experience and saying no, but in 50 years, I don't know. I really don't. Patients
still want the human touch. I don't think there's any doubt about that. And that kind of interaction and being able to sit and take time with them, I think is still really worthwhile. So watch this space. I love this idea because it also kind of bleeds into something that has been, something that I've been thinking a lot about, which is what does a cure for cancer look like?
Boy, I mean, a cure for cancer, obviously, that'd be the greatest thing that medicine could do.
Yeah. What a moonshot, huh?
It seems like a moonshot, but I don't know if it's inconceivable. I mean, obviously, that's what these companies are looking for, but I don't know. It is. Well, I mean, we're getting better. The treatments are better. We've kind of hashed on that or gone over that a little bit. But the cure is the ultimate goal for all of this is the cure for whatever disease state may be, but cancer, absolutely.
It certainly seems like there's genetic change. There has to be. That's the only thing that can really drive the cell differently. Okay, it could be epigenetic, but some sort of change in the DNA of that cell that allows it to all of a sudden escape its typical senescent bonds. And it's the same thing that if you go from a contained cancer that all of a sudden goes to spreading via lymphatics or hematologic, that had to have been a genetic change. And that's what you're looking for in something called oncotypes. You want to talk a little bit about oncotypes?
Oncotypes, a tool that we use I call it a chemo decision tool, because that's basically what it is. So what it is, it's a genetic test used for breast cancer patients. They have to have a certain pattern of breast cancer, a certain subtype of breast cancer. So it's the majority of breast cancer patients are candidates for oncotype. It can't have metastasized. And what we'll do is it's a genetic test on the cancer genetics. So the trick about genetics is we all think genetics is what we got from mom and dad. So those are called germline mutations, or what are inherited. Somatic mutations are acquired, or what is the cancer genetics that's different. So an oncotype looks at a number of genes, and based on its patterns of expression, whether it's there or not there, they assign each gene a number, and then they come up with a recurrence score. And the score, it's not a percent. Patients fall into that trap. If we tell them they have a 5, they think, oh, it's 5%. No, it's just a number on a scale.
Right.
It's like a blood sugar. It's a number on a scale. If it's above this number, it's a yes or no. We will recommend chemotherapy, whether you take it or not. That's up to you. So if they have a high recurrence score, we'd recommend chemotherapy for prevention. And then there are numbers associated with it, percentages of, what percent are going to metastasis at 9 or 10 years, et cetera, et cetera. If it's below that score, there's almost no benefit to chemotherapy. So what it tells me is what we always traditionally were taught on pathology is, what does it look like on the outside of the cell? It's like buying a house. If you drive up to a house and you say, wow, that's a beautiful piece of property, I want it, you would never buy it without walking inside. And that's what these oncotypes and these other genetics too, they open the front door and you look inside, and what's the DNA on the inside of the cell? So what we're learning is DNA is more important than what we see histologically. So it's the code. It's the instruction code that drives everything, recurrences, metastatic potential and all that. And that's what all these scientists are trying to figure out at this point. It's not you and me doing this in our labs. It's all these academic centers, and they come out with all these new tests. And the problem is now we're getting so flooded with these oncotype-like tests. I'm not saying oncotype competitors, but tests that are similar to them, or look at DNA, predictability patterns. And, every 3 to 6 months, we get a new company saying, mine's better than that one. It's like, well, this is the one that's been the gold standard. We're comfortable with it. We're resistant to change because we're comfortable with these numbers. It's validated. It's tried and true. Oncotype's been around 20 plus years. Or 20 years, it's just what we're comfortable with. And we trust the company that developed it. So they come up with new tests. We're more willing to go with what they have than some biotech I've never heard of. But right now it's a mess.
Well, it's also interesting because now you're looking at the genotype of the cancer. And so if it's flipped whatever switch that we have, that genetic marker that says this is much more likely passed into metastatic cancer, even if you don't see metastases, you're going to treat it as, just because it's very specific to us now that this is telling us this has escaped the local bounds.
Absolutely.
Yeah, and that's a really phenomenal technology, because it's not that we're seeing these in distal sentinel lymph nodes or anything like that, or distal spots. We just say, oh, this has the exact characteristics that we see in metastatic cancers, therefore we're going to treat it that way.
Absolutely. It's a fascinating time now. The kind of up and coming things that are kind of superseding oncotypes and everything else are these tests that look at what is called circulating tumor DNA. So cancer cells, as they die off, just like any other cell, they release DNA into the bloodstream. So now it's a DNA fingerprint, much like if I leave a drop of blood at a crime scene and I did, it's my blood there, they're going to come back to me and say, the DNA pattern is you. It's, 1 in 7 billion chance it's somebody else.
Yeah.
Well, they can fingerprint their own cancer. So somebody comes in with colon cancer or whatever, we'll take the tissue block, send it to the lab. They'll fingerprint that specific cancer, and then they'll make a probe. So what we do is we'll get a blood test, and if they detect any of that DNA by that probe, it'll be a positive test down to some sensitivity.
Of course.
I can't pick one cancer cell in your entire body.
Not yet.
But it's much more sensitive than imaging lab work that we have, because everybody wants to know, well, I want a test to tell me if I have cancer. I'm like, well, there's not one.
Yes.
Or I want to scan my whole body. Well, you understand that comes with risks of radiation exposure, an allergy to contrast, I don't know, whatever. And everybody wants all this. And it's like, well, these tests I think are for medicine in the next 10 years, they're the holy grail of the sorts as far as detection. The next step will be what are the holy grails for treatments for these? And do we treat somebody with a positive blood test that doesn't have a positive scan? And I had this discussion 10 minutes before I walked in. Somebody with a positive blood test and a negative scan. I mean, they're looking at trials now. Should we treat these patients before they get radiographic progression? And, all of us in our deep down inside say yes, but then when do we stop treating them? Do we do it 3 months, 6 months? Well, the test goes to 0, then do we stop? We don't know. So it's a fascinating time, but I've been saying that every 5 years. I say it's a fascinating time. Well, these new things come and you're excited about it. And you're like, oh my gosh. And then you try and explain it to the layperson. They try and read about it. And it's just hard to explain it. And then you get a layperson that has a positive blood test with a negative scan. Well, the shoe's going to fall off. We just don't know. 3 months, 6 months, 5 years. I don't know. So then you got to deal with the emotional aspect of it weighing on their mind. Are they going to change their behaviors in life? Are they going to become more reckless because now they think their cancer's coming back? And there's more to it than just a positive or negative test. I don't think that's well appreciated by a lot of docs. I think overlook that. And I don't think that's well appreciated with patients either. They just want to answer now, and we give it to them and say, and then they do with it what they may.
Of course. No, that is so well said. And I mean, I think you covered a lot of really high yield topics right there. I will often say to patients, look, I can find something wrong with you. I can look hard enough and find something. Maybe it's never going to affect you. I don't know, but we got to be careful about the questions that we ask, because we might get answers that we don't know what to do with there. And you said it exactly right. Now we've got this positive test. Well, what do we do about it? Well, I don't know. I mean, there's certain things that you can say, if you have major macroscopic tumor, well, yeah, you've got cancer. That's Absolutely. Easy enough for us to go. That algorithm's pretty tried and true. But once you get to the microscopic level, do we even know what we're treating? How are we going to measure that we're actually treating something? How many cycles of chemotherapy do you give somebody that's just got a positive test?
And
we don't
even
know.
Targeted treatments don't come without potential life-threatening toxicities. Yes. I mean, our immune therapies, patients die from immune therapy complications. It happens.
Yes.
So these aren't harmless drugs. People think I give them an oral therapy. They think, oh, great, I don't have to get IV chemo. It's like, wait, the side effects are different. Most are well tolerated,
yes.
But here's the other potential problems. And educating patients can be quite a hurdle sometimes. And we do the best we can, give them handouts that are in lay terms as best can be done.
Sure. Well, I have patients oftentimes that are taking some sort of hormone treatment of some type and say, I'm having this chemotherapy, and where does that fall into the line? It's not worth it for me to try and correct this kind of thing. It's you're getting treatment for your cancer, hopefully, and whether that's preventative or active, it's hard to say. And it's also got to be hard to get patients to get up for another treatment. You have to lay out for them, look, these are the things that we can do. There are some things that we should do. Everything's on the table here for you. You can ultimately decide. I will certainly guide you towards certain things. Same thing with heart failure and other issues. One popular treatment that crosses over in our side is doxorubicin cardiomyopathy, which is a specific type of chemotherapy that is utilized that is pretty cardiotoxic. And so we have to kind of it turns out if you cause your heart to not function very well, that can oftentimes kill you before the cancer will kill you. And so we have to be cautious. This is an interaction between a kind of burgeoning field called cardio-oncology, which takes into account these kind of things. And so it's a neat crossover in our worlds, I guess.
Yeah, we've definitely shared patients in common with this. And I bet you get the same too. Is I think one of the most challenging things with patients right now is the misinformation on the internet about non-alternative therapies. The biggest one I hear about, until I'm almost to the point where I don't even want to answer the question, is ivermectin and febendazole. These are antiparasitics, and people are saying, I'm not going to take this potential therapy that has been tried and true. We know it works 90+% of the time. I'm going to take this holistic approach and try ivermectin, which I give to my dog for heartworm prevention, and
it's good at that.
Yeah. But we hear it all the time. It's these alternative options that people are doing that just aren't standard of care, and then they get hostile towards you when you tell them that's not reasonable. I don't think. Have you researched this? And they pull some study from 1965 that they read about on an AI bot, and it's like, yeah, well, why don't you pull one from like 2025?
Of course. And, this is leaving all politics aside here. That's not at all. We're here to help people. That's what we really want more than anything. But this is, I'll have patients that come to me. Typically, it's about statin-related stuff. And they'll say, like, did you know about this blank about statin? And I try and as diplomatically as possible and say, yeah. This is... I've had 20 years of doing this kind of, yes, I have to know this kind of stuff. I know the good and the bad. I know the formative trials. I would almost guarantee you to a man, if they come to you, they have not seen the formative trials for statins, because then you would see significant positive data that comes out of that. And I'm not saying they're a panacea, but it's the same thing with, I'm trying to let you, I don't want to say that ivermectin is not going to work. I don't know that it's not going to work. I have proof that these other things can help you. I can prove to you that this can happen with formative trials that have shown this kind of thing. And that's the barrier to entry that we have in the allopathic side that
Yeah, there's some distrust out in the lay community. Fortunately, it's a small percentage of patients, but there is some distrust with traditional medicine. And I mean, we've seen the infomercials 20 plus years ago that there's things doctors are doing that they're not telling. We know how to cure everything, and we're just keeping it to ourselves for some ultimate financial gain.
Exactly.
It's like, no, you don't understand. I don't know. I don't know. It comes up periodically. Usually, I don't usually see those patients back for a second time. That doesn't usually end well.
They'll find somebody else that can do that.
Well,
no, it doesn't. It doesn't. So let me ask you about what are your recommendations to young health professionals that are going into your field now?
Oh, I thought you were going to ask me, what do I tell somebody young in high school or getting ready to go in college about doing medicine?
They've already crossed the Rubicon here, and they're going in for it.
You should ask me that question. That's a much more interesting question with an answer.
Yeah.
Go into plumbing, HVAC, or
That's
electrician.
That's right, HVAC work. Yeah, that would be
fantastic. Because all the guys my age that I grew up with, they've all retired and sold their company and are all fishing somewhere.
They've got a big boat, too, all of them. Yeah, no, I see that a lot. Yeah.
I'm sorry, ask the question again. That was a smart aleck answer.
No. That's look, you can take that wherever you want to, but for young oncologists that are coming out, what do you have any advice for them?
Oh, absolutely. I mean, I think all senior docs to a certain degree, especially in private practice or academics, I mean, we all have experiences, pluses and minuses, going whatever route we chose. I mean, the first question is, do you want to work for a hospital or do you want to go in private practice? Hospitals will offer you the world to join with them, but what they don't understand is contracts are always renegotiated.
Constantly.
Yes. And it may be you have a 3-year contract, maybe you have a 2-year contract, but it's like being a sports star. I've got a 3-year contract, I'm getting this out of my 3-year contract. Well, at the end of my 3 years, they're going to many times renegotiate and say, well, you haven't met this metric.
You're supposed to really see 20 patients a day. You've been at 17. Now, we haven't brought you those patients, but either way, that was the contract. So we're going to pull you back a little bit. It's a constant discussion.
Yes. Mm-hmm. So that's, and they don't understand that coming out of fellowship. They see all they look at is the dollar differences. They look at it as financially, which I'm not saying I disagree with that. I understand because you haven't made a living yet because you've been in school your whole life. Mm-hmm. And then they choose the academic route or the employed route, I should say, not academic, but employed route.
Yes.
And they just don't have the knowledge. They're promised the world by a non-physician CEO.
Correct.
And, they sign on the dotted line, they have kids, buy a house, now they're ingrained in the community, and the hospitals or employers know all that because it's hard to move your kids. They don't want to leave because my best friend Johnny over here or whomever, we have our best friends on our street, we're ingrained in the neighborhood, and now I've got to move. That's not going to go well. And then, like I said, you got to start over again. So then you got to start and build a practice, which there are some lean years when you're in private practice because you're building a practice. So then the private practice options are different. Is it partnership track? Is it not a partnership track? So that's advice for a new oncologist. Geography, big cities, you may like the amenities of a big city, but there's also things you're not going to like. And competition is a real thing in a big city because everybody wants to stay in big cities because that's where we train. We're comfortable staying where we train. We know we don't like change. Mm-hmm. Most people don't. I mean, we're not military moving every 3 years.
That's right.
So that's the big advice is, and you got to interview them as much as they have to interview you. The problem is you usually only interview them for about a day and you make a life decision in a day based on interviewing a group with 6 docs with all different personalities. One doc might be conveniently on vacation that week intentionally. You don't know that, you're interviewing. So there's all kinds of interview advice that they need to get from mentors. business advice from mentors. I mean, there's just it's a wealth of information that none of us get in fellowship.
But you don't have time for it. And then all of a sudden, I mean, I got 0 business classes. I don't know what a profit and loss sheet is. I had to figure that out all the time. Oh, absolutely horrendous. But, and so, that's really sage advice. I think what you really kind of glean down to is like, what is your purpose? What do you really want to do? Where do you really want to be? Start thinking about these things. These are really important to you overall because ultimately, most of us, we're not avaricious. Money is not the answer to everything. You're going to get paid. You're not going to starve. You're going to be able to go out to eat dinner. Those things will be there. So find out the kind of lifestyle that you want. Do you want to be able to golf cart to your kids' school? That's a good thing. Tell me about what you do for fun. What are your hobbies?
Yeah, it's tough. It's tough right now as we're trying to actively.
Is work a hobby?
Yeah, unfortunately, it seems like it at times. But I mean, fortunately, I like what I do. I have a great staff. We have providers, PA and Ps. That always makes it helpful for us. They support us tremendously, and it's the practice can't survive without everybody that's in it. Hobbies for fun. I do like to fish. I just don't get a chance to do it as much. I must get asked every time I'm on vacation how the golf game was. I don't play golf. Don't care for it.
Either,
I don't like it. And patients always go, "Oh, they're shocked by that." A doctor
Are
doesn't
you even
play
a real
golf.
doctor? I mean,
Certainly like the beach and stuff. So I like the water. Grew up on the water, so I've always been around it. So that aspect of it is what I like to do.
Yeah, when you do get that free chance, and again, you've got a busy practice, but also seeing your family occasionally is nice.
Yeah,
those are good things.
Travel, go back to Savannah. My parents are still living, so
awesome.
We go back pretty regularly, go catch up with old friends, because I grew up there, see old buddies from high school, et cetera.
Yeah, it's nice that that's drivable from here. So
definitely.
Yeah. Okay. I'm conscientious of your time and really appreciate your. Don't look over there, okay?
Yeah,
and,
I guess I'll have to.
Let me tell you this.
Here
we can. But I am going to end up with some rapid fire questions here for you. Okay,
I can't wait.
This is everybody's favorite. Here, let me start off by saying, who is the smartest person in history?
Einstein.
So, hey, great answer. We love that here. It's a popular answer here, and we agree with it.
Well, you start thinking about like mentors and training and all that. I mean, you get touched by so many different docs and training they're geniuses, and they seem to know everything, especially when you're at that part of your career you're learning. And you think about all the attendings I've been exposed to in my career, and I was like, well, half of them were probably geniuses, but I threw that one out there just because nobody can argue with Einstein.
No, nobody can argue with that. And it reminds me of when we were doing history and physicals in our third year of medical school. And one of my attendings, Dr. Levine, who is an endocrinologist, I started off
not this one.
No, different one. And I started off with my patient presentation. I said, this is a such and such year old who's got bilateral nephrogenic. And he goes, hold on. Bilateral? I was like, yes, sir. And he goes, it sounds like retroperitoneal fibrosis. And I was like, okay. Anyway, so I'm still amazed by that to this day. So smart guy.
Smart guy.
If we can live to 1,000, should we do it?
No.
Okay.
We'll be overpopulated before we know it. I guess we'll have to move to Mars.
Go to Mars. Yeah, exactly.
Yeah.
My kids might be able to get off the planet. We'll see.
That's a tough question. Who asked that question?
Me. This is who asked this question. Okay, you're
But then I
Amaranthian host.
say no, then people are gonna be like, "Well, he's a nihilist. He wants to." It's like, no, I don't know the answer to that, but no, my gut instinct is no.
Okay.
Because I guess the question would be, what's my quality of life going to be from years 100 to 1,000? I don't know. If I'm sucking on a straw and not enjoying, I'm not functional.
That's right.
Then maybe not. So that's why I said no. You don't ask for explanations.
I don't. I leave it open.
We'll give them to you.
Now, one of our former podcast guests, Tom Mayer, had suggested this idea of not just lifespan or health span, but joy span.
Yeah, I like that.
If you can keep the joy span going,
that may
change. That may change that.
That I do like. That's absolutely relevant.
Yeah. Do you like it too cold or too hot at night?
Too cold.
Okay, good. That's the right answer. Only one. What is one thing you would tell yourself if you could go right now to talk to you as you started med school?
Get into electrician, HVAC, or plumbing.
Sage advice to you back then.
Seriously, I'd go get a trade. I mean, it's not to discount what we do.
No.
I mean,
it's
the public.
It's good advice.
I mean, all the public has been piped into my entire life. Growing up in a doc's family is, you tell somebody, "Oh, my dad's a doc," they're like, "Oh," it's like they take a whole different attitude with you because they go, "Oh, a silver spoon." It's like, I don't think you understand the sacrifices we make. None of them do. I mean, we're all buried in debt from college. We're buried in debt. I went to grad school, et cetera. But besides college, med school, you don't make money in med school. Unlike all the law students that lived in my crack house I lived in Macon, Georgia, they all had a job. They could go out and do stuff. They went out and did social things at night, and these are law students, which I thought were like us. And, I don't want all the lawyers to call me with this, but
no, we'll edit this out, Chris. So it's fine.
But I mean, literally, we can't have a second job. We're massive amounts of money in debt. And then you go off and be a resident, you're making $2.20 an hour because you're working so many hours. Mm-hmm. And then all of a sudden, you finally get to your career where you can make a living, and then you got to pay back all this debt that's in these high interest loans. Many of them now, I wasn't fortunately, but many of them now, because interest rates were really low. But I don't think people understand the sacrifice, because all my friends, they have kids, they got a car, a house, and I'm driving an old 20-year-old vehicle that barely starts, and they just don't understand it. So it's a huge financial sacrifice. But that's why I say, I think I'd do medicine again. I don't want to sound like I wouldn't go back into medicine.
I think your point is well taken.
But I think if I'm in high school, I think the tradesmen are going to take over the world. Mm-hmm. I mean, these kids can't look up a YouTube and figure out how to change a light bulb. There's a problem. And that's right. The issue. The tradesmen are going to come in and say, "I'll charge you $50 to do that." And they'll do it because they can't figure it out.
Yeah, of course. No,
that's an explanation for that.
I like that sage advice here, okay?
It is what it is.
Let's say here, what is one current medical treatment or therapy we are going to shudder at that we use 15 years from now?
Wow. I can tell you what we're going to shudder at in 15 or 20 years. It's not medical, it's plastic. We're going to think we're morons for plastic over the last 100 years of what we've done to this entire world. They're going to be digging up plastic 1,000 years from now and going, those idiots in the 21st century.
Right.
So besides the point, as I drink out of my plastic bottle, notice I didn't open it yet.
We'll get a glass for this next time.
No. Shudder at? Boy, I don't know. I hadn't even thought about that. I think we're going to look at chemotherapy and say, what the hell were these guys doing? And then they're going to say, well, that's all we had. Because they're horribly toxic. There's fatalities associated with chemotherapy. But if you look at historically in medicine, if it's all you have, I mean, we give arsenic, for crying out loud, in our office for certain leukemias. I mean, arsenic's poison.
Yes.
I mean, okay, everybody knows what arsenic is. They put in pressure-treated wood years ago. It's just how much of the poison can we give and it be effective to treat disease. But yeah, I think people look back and be critical of chemotherapy. I don't know, 15, 20 years from now, I think 50 to 100 years from now, they'll say, God, what the hell are these oncologists doing? They're causing secondary cancers, they're causing this. But I mean, that's a trade-off, risk versus benefit.
I love this answer because I think something similar. At some point we're going to get some spark moment, some eureka moment where we find out, this is how you treat cancer, and it's something off the wall. Maybe it's plastics. I don't know. But the point is that there's going to be something that comes along that says, oh, we don't any longer have to utilize chemotherapy for that kind of thing. And that'll be a great day whenever we get there. Two more, okay? You ready? Tell me, what is the greatest song of all time?
Stairway to Heaven.
Beautiful answer. Love it.
Although Bittersweet Symphony is another one. That's my 1 and 2, so I'll go with 1 and 2.
Bittersweet Symphony, very interesting. Have you heard the Bittersweet Symphony without the Rolling Stones cover portion in it?
Yes, so I've heard so Bittersweet Symphony was a Stones song, and it's a musical.
You're talking about the Stones song?
Yeah, it's a musical song.
Yes.
So they took that riff in they took it and put it in their thing, and they got no royalties from that.
They got zero royalties.
They got zero every time it's played on TV, whatever. I think Keith Richards or one of them finally started giving royalties in the last 5 years, but the first 20 years they got zilch.
Well, if you hear it, it's definitely a part of the song. You can hear the actual OG Bittersweet Symphony, which is a very cool part. but it's not the violin part or anything that you would think stands to your ear as the part of the verse version of Bittersweet Symphony. So
yeah, it's odd that they got
slapped
hit
on
with
the
that
part.
For
Exactly.
It's not like Ice Baby or the other ones where it's
that's
clearly a copy of somebody's
clearly
song.
100%. Yeah, this but when you take that part out, it adds a little something. But unless you're really listening to it, you wouldn't hear the difference without that. So very interesting segue there. Okay, and finally, tell us what books you're reading right now.
Actually, Old Man in the Sea.
Ah, great.
And then there's a doc in Savannah that is a murder mystery writer. His name's Mark Murphy. He has a new book. I've read the first couple of pages. It looks like it's going to be good. His first book wasn't as good as this one appears to be. Somebody encouraged I read it. So I've got a few pages in it. I don't read a lot of pleasure reading during the week. If I'm on vacation or something like that, so I'll set it down and pick it back up in a couple of months or something when I'm on vacation. But I do read New York Post religiously every day. I never miss that without... well, maybe on a Saturday or something, I might overlook it if I'm out of town, but I read that every day. But yeah, book. What about you? What do you got open right now?
I've always got a few books that are going on. One of them is my wife and I are both listening to the Dan Brown book. Secret of Secrets, which is kind of a page turner that we'll listen to on Audible. I am reading a book on the quantum mechanical basis for evolution by natural selection, which is it's a heady tome that is really
maybe I need to rephrase the smartest man I know from Einstein.
No, you shouldn't. And the last one is Man in the High Castle. Man in the High Castle. Which is Philip K. Dick.
That was an Amazon series about 10 years ago, wasn't it?
Yeah.
It's an interesting concept with the East and the West, and then the middle.
It's a counterfactual history of if the Axis had won World War II.
Yes, Fatherland. It's the modern version of Fatherland.
Yeah. So it's interesting. I mean, it's a neat take on things. So
it is a neat take on things.
But it'll be the same 3 books that I'm reading when you come back to do this podcast again in 6 months. So I'm not exactly churning through them.
The Hemingway thing is like my favorite place on the planet is Key West, and I was there not long ago, and I was like, I hadn't read any Hemingway in a million years, and I wasn't a big fan of it in high school, so I was like, maybe there's something to it. Maybe I need to reread it as an adult. So that's kind of where I'm stuck.
Yeah. Something about 6-toed cats or something. I don't know.
There's a lot of them.
There's quite a few of them. Well, look, I can't thank you enough for being here today. I can't thank you enough for being in our community, helping all the people that you're doing day to day. Also being a colleague and a friend and somebody that I can bounce off ideas and ask you about things like the cure for cancer and say, hey, I've never heard of this chemotherapeutic. Can you help me with this?
Of course I need it. Well, it's a two-way street.
So we really appreciate everything that you're doing for us here.
Well, thank you.
And thank you for being both erudite but also really approachable. So that's really just great for our community. So
thank you.
Thanks for being here today. Thanks to Dr. Christopher Haberman for being here, for teaching all of us, for talking with us today. And thank you for helping us make medicine better together.